Welcome to the deep dive. We take the stuff you need to know, pull out the really crucial bits, and, well, make sure you feel totally on top of it without getting overwhelmed.
Yeah, think of it as us sorting through those dense notes so you get the core understanding nice and quick.
Exactly. And today, we're tackling a really important one based on some revision notes we've got here. Subdural haematoma. SDH for short. So our mission really is to create a super clear, high-yield guide for you, covering SDH from, what it is, right through to the complications.
And we'll throw in some memory aids, too, things to help make it stick. We're basically just using these revision notes as our map.
Perfect. So think of us as your revision buddies for this one. Okay, let's dive in right at the start then. What is a subdural hematoma?
Okay, so fundamentally, it's blood collecting where it shouldn't be in the subdural space in the brain.
Right.
If you picture the brain, it's got these protective layers, the meninges. There's the tough outer one, the dura mater.
Okay.
Then underneath that, a more sort of web-like layer, the arachnoid mater. And then closest to the brain, hugging it, is the pia mater.
Got those layers. So the subdural space, where's that?
It's the potential gap between the dura and the arachnoid. It's not usually an open space like, say, the subarachnoid space, which is below the arachnoid.
Ah, okay.
It only really becomes a proper space if blood or sometimes fluid collects there. Just to be complete, above the dura between it and the skull, that's the epidural space. Another potential one.
So blood collecting between the dura and arachnoid. Makes sense. Now, the notes mention classifying them. How does that work?
Yeah, we usually classify them in a couple of ways. First, by how quickly they show up after an injury.
Okay.
So you've got acute SDHs, they present pretty quickly within the first few days. Then subacute, which pop up maybe 3 to 7 days later.
Right.
And then chronic SDHs, which are much slower, developing over, say, 2 to 3 weeks.
Weeks. Okay. And the other way?
The other way is whether there's damage to the brain tissue itself. So a simple SDH means just the bleed, no underlying brain injury.
Right.
Whereas a complicated SDH means there is associated brain injury,
Yeah.
like a bruise on the brain, a contusion.
Okay. Acute, subacute, chronic for timing. Simple versus complicated for brain injury. Got it. Any quick trick to remember exactly where this bleed is?
Yeah, try this. Subdural is subdural. It's under the dura.
Oh.
Helps distinguish it from epidural, which would be on top of the dura. Simple, but hopefully effective.
Subdural is under the dura. Like
Yeah.
it. Okay, so we know what it is, how we categorize it, what actually causes it, what's the etiology?
Well, the vast majority of the time, it's trauma.
Yeah.
A head injury.
Right.
What happens is the force, the movement of the brain inside the skull, can tear these things called bridging veins.
Bridging veins.
Yeah, they're quite delicate veins that run from the brain's surface across that subdural space to drain into the big venous sinuses in the dura.
Okay, so they bridge the gap.
Exactly. And because they're stretched across that space, if the brain moves suddenly, they can tear. And that's where the bleeding comes from, into the subdural space.
Makes sense. Are there other causes, less common ones?
Yes, definitely less common, but you can get spontaneous bleeds, maybe in someone with a bleeding disorder, a coagulopathy, or someone with abnormal blood vessels like a vascular malformation.
Okay, mostly trauma, but not always. So who's particularly susceptible? Who are the high-risk groups?
Several groups stand out. Advanced age is a big one.
Why is that?
Well, as we get older, the brain tends to shrink a little cerebral atrophy. This can actually stretch those bridging veins, making them tighter and more likely to tear, even from a minor bump.
Oh, right.
Chronic alcoholism is another major risk factor. It can affect platelets, leading to thrombocytopenia and also clotting times. Plus, alcohol abuse can also cause cerebral atrophy, adding to the risk.
Okay.
And then anticoagulant use medications like warfarin that thin the blood obviously increase the risk of any bleeding, including SDH.
Sure.
Also, anyone with a history of falls or previous head trauma or underlying bleeding disorders like hemophilia.
Sounds like older people and perhaps infants might be key groups.
Absolutely. For infants, their bridging veins are really fine, and forces like shaking can tear them, which is why, tragically, it's linked to non-accidental injury.
Well, the notes mention some stats there.
Yeah, about 12.5 per 100,000 in the 0-2 age group, rising to 24 per 100,000 in the first year. And non-accidental injuries a factor in, like 57% of those cases, it's significant.
Wow.
And for the elderly, as we said, it's the brain atrophy and weaker veins. And definitely don't forget those with chronic alcoholism, the combined effect on clotting and brain structure.
Okay, that paints a very clear picture.
Yeah.
So let's get into the mechanism.
Okay.
Once those veins tear, What's the actual pathophysiology? What happens step by step?
So the vein tears. Blood starts leaking into that subdural space. Because it's a confined space, the blood builds up, forms a collection, the hematoma.
Right.
This hematoma takes up space, obviously, and starts pressing on the brain underneath. It increases the pressure inside the skull.
And that pressure causes the problems.
Yeah, exactly. That pressure disrupts normal brain function, leading to all the neurological symptoms we see. In an acute SDH, this is often from those acceleration-deceleration forces tearing the veins.
Like in the car crash.
Yeah, or a significant fall. Sometimes, though, bleeding can come from damaged arteries on the brain surface too, cortical arteries. And while trauma is most common, remember, acute SDHs can also happen with clotting disorders, vascular issues, even aneurysms sometimes.
Okay. And what about the subacute and chronic ones? How does the process differ over time?
Well, over days to weeks, that initial blood clot starts to change. In the subacute phase, it gets more organized.
Mm-hmm.
Then, moving into the chronic phase, the clot can actually start to break down, liquefy, and it might form membranes around it. This collection can slowly expand, maybe drawing in fluid, causing that more gradual increase in pressure.
Which explains why the symptoms can be so much slower to appear in chronic cases.
Precisely.
Okay, this is where it gets tricky for diagnosis, isn't it? With these varied presentations, what else could it be? What's on the differential diagnosis list?
Oh, absolutely critical. You've got to consider other things that cause similar neurological symptoms, especially after trauma or with gradual onset.
Like other types of brain bleeds.
Exactly. Top of the list, epidural hematoma that's bleeding above the dura, intracerebral hemorrhage bleeding within the brain tissue itself, and subarachnoid hemorrhage bleeding in the space under the arachnoid layer, where the CSF is.
Okay, so other bleeds, what else?
Brain contusion, just a bruise on the brain. Ischemic stroke, lack of blood flow, they can present similarly sometimes.
Right. Any non-vascular causes?
Definitely. Infections like meningitis or encephalitis, a brain tumor, particularly, it bleeds acutely.
Okay.
An evolving stroke can sometimes mimic a slow bleed. And various metabolic problems, think DKA, sepsis, severe liver or kidney disease, they can all cause confusion, altered consciousness.
And systemic illness, too.
Yeah. Even worsening dementia or, any growing lesion like an abscess or maybe toxoplasmosis in an immunocompromised patient. Basically, especially in older people, any new confusion needs SDH on the list of possibilities.
That's a lot to keep in mind. Is there a shortcut? A mnemonic, maybe?
There is a pretty useful one. Think heads.
Heads?
Yeah. H for hematoma covering epidural, subdural, subarachnoid. E for encephalitis or encephalopathy. A for abscess or tumor. D for dementia or drugs, including those metabolic causes, and S for stroke.
Heads. Hematoma, encephalitis, encephalopathy, abscess tumor, dementia, drugs, stroke. That's actually really helpful.
It covers a lot of the big ones you need to rule out.
Okay, great.
Yeah.
So we know what it is,
Yeah.
the risks, the process, what else it might be. How common are subdural hematomas? What's the epidemiology look like?
Well, the notes give a UK figure of around 13 cases per 100,000 person years.
Okay, not insignificant.
No, and interestingly, the incidence in the UK seems to be going up, though the reasons aren't totally clear. And as we've said, it's definitely more common at the extremes of age, infants, and the elderly. Strongly linked to severe head injuries, and becomes more prevalent as people get older. Oh, and the notes mention it's rarely caused by something called spontaneous intracranial hypotension.
Good to know. So incidence is rising, especially affects the very young and old, linked to trauma. Now, the crucial bit, how does someone present? What are the typical clinical features?
Common things you'll hear about or see are headache, altered mental state, and that's a spectrum, from just a bit confused to completely unresponsive.
Right.
Nausea, vomiting are common too, sometimes seizures, and focal neurological deficits like weakness down one side or speech problems, depending on where the pressure is. Often these symptoms get worse over hours or days.
And is there a difference in how acute versus chronic ones tend to show up?
Yeah, often quite distinct. Acute SDH usually follows a pretty significant head injury. Maybe they lost consciousness initially. Sometimes there's that lucid interval. They seem okay for a bit, then deteriorate.
Okay.
Chronic SDH, though, that can be much more subtle. It might be 2 or 3 weeks after what seemed like a really minor bump, especially in someone older, maybe on anticoagulants or with alcohol issues.
Right, the insidious onset.
Exactly. Symptoms can be gradual, maybe just loss of appetite, feeling sick, a persistent headache that just won't go away, maybe gradually worsening confusion or weakness. That headache is a real flag if they have clotting issues or drink heavily.
So a low threshold for suspicion in those groups. What about the physical examination? What are you looking for?
full neuro exam is key. First, the Glasgow Coma Scale, GCS, to get an objective measure of their consciousness level.
Standard.
Check vital signs. Watch out for that combination of slow heart rate, bradycardia, and high blood pressure, hypertension. That can suggest raised intracranial pressure,
I
ICP.
think Cushing's triad, right, although often incomplete or late.
Exactly. Then the neurological exam, proper pupil size and reaction to light are crucial. Look for papilledema with an ophthalmoscope swelling of the optic disc, another sign of raised ICP.
Okay.
Also look for any signs of head trauma externally. In babies, feel the fontanelles, are they tense or bulging? Check for bruising or purpura elsewhere, could suggest a bleeding problem or even meningitis. And always consider non-accidental injury in children.
Lots to assess. And the specific signs depend on the bleed location.
Yeah, the neurological signs really vary depending on where the hematoma is pressing and how quickly it developed.
Okay, so history and exam point towards SDH. What investigations confirm it?
Right, you'll need some tests. Bloods first, full blood count, urea and electrolytes, liver function tests. These help check for other causes of confusion or illness.
Makes sense.
Specifically, look at the platelet count. Low platelets increase bleeding risk. And a coagulation screen is vital to check for clotting problems. Also, a group and save, just in case surgery is needed quickly.
And imaging. That must be critical.
Absolutely essential. Urgent neuroimaging is the priority if someone has impaired consciousness, confusion, or signs of raised ICP.
And what type of imaging first?
The go-to initial scan is usually a non-contrast CT head. It's quick and very good at showing acute blood. For subacute SDHs, sometimes blood can look similar density to brain tissue on a non-contrast CT, so you might need CT with contrast, or sometimes an MRI scan can be better. Chronic SDHs usually show up well on a standard non-contrast CT.
And if it was major trauma?
Good point. You'd also need to image the cervical spine, rule out a neck injury, and maybe a wider trauma survey depending on the mechanism.
Right. So CT confirms the SDH. What's the management plan then?
The general approach is stabilize, support, and then decide about the hematoma itself. Does it need surgery or can we watch it? And of course, treat any associated injuries or underlying conditions.
Okay, stabilize first. What specific steps are involved?
If it's serious trauma, see spine immobilization, called the trauma team. Always ABCs first: airway, breathing, circulation.
Right.
Intubation might be needed if their GCS is low or they can't protect their airway. That's a senior decision. Get that head imaging urgently, but make sure they're stable enough for the scanner and have experienced staff with them. Urgent neurosurgical referral is key. If there are signs of raised ICP, start managing that. Things like head elevation, maybe specific medications.
Okay.
If someone's deteriorating very rapidly, the neurosurgeons might even do emergency burr holes at the bedside to relieve pressure before a formal craniotomy.
Wow, okay.
Definitely treat any coagulopathy, reverse anticoagulants, give clotting factors if needed. Get the patient as stable and optimized as possible before any transfer or surgery.
And what determines surgery versus observation?
Well, small acute SDHs with no symptoms might just be observed closely with repeat scans. But surgery is usually needed if there are focal neurological signs, if the patient's deteriorating, if the hematoma is large, if there's significant midline shift on the scan, or clear signs of raised ICP.
And the surgery is usually?
Typically, an emergency craniotomy, opening the skull to evacuate the clot. They often leave drains in afterwards to stop it reaccumulating, which apparently reduces recurrence risk significantly.
Right. Makes sense. Is there a memory aid for those surgical indications?
You could think surgical indications: size, symptoms, shift, speed, size of the hematoma, presence of symptoms, degree of midline shift, and speed of deterioration.
Size, symptoms, shift, speed. Nice. Okay, so that's management. What are the long term? What's the prognosis like?
Honestly, it's highly variable. It really depends on things like the hematoma size, the patient's age, their general health before the bleed, and how quickly they got treatment.
Oh.
For acute SDHs, the mortality rate can be pretty high. The notes mention up to 60%, with an overall range across all types, perhaps 30–80%. It's serious.
That's sobering.
It is. Younger patients tend to do better, generally. A lot depends on the extent of the initial brain injury itself, not just the bleed. Good functional outcomes.
Well, they're seen in less than a third of patients, unfortunately.
So many survivors have lasting issues.
Yes, many don't fully regain their previous level of functioning, which highlights the importance of prevention, if possible.
What can be done for prevention? It's mainly about tackling those risk factors. Avoiding over-anticoagulation, big focus on fall prevention in the elderly, especially if they are on anticoagulants, and addressing alcohol dependency.
Targeting the risks. Makes
Right.
sense. Finally, what are the potential complications we need to be aware of?
There's a fair few, and some are immediate threats. Brain herniation is the big, scary one, pressure pushing brain tissue where it shouldn't go.
Life-threatening.
Absolutely. Seizures can happen acutely or later on. The SDH can recur or become chronic even after treatment. Patients can be left with permanent neurological deficits, paralysis, cognitive problems.
Okay.
Infection is a risk, especially after surgery like empyema or meningitis. Post-traumatic hydrocephalus can develop. Raised ICP and cerebral edema are major issues in the acute phase. And sadly, death, often from brainstem herniation or survival, but in a coma or persistent vegetative state.
A really serious list of potential problems. So just to pull it all together for everyone listening, SDH is blood under the dura, usually from torn bridging veins after trauma.
Right. Key risks:
Yeah.
age, alcohol, anticoagulants.
Presentation varies. Headache, confusion, worse neurological signs. CT is key for diagnosis.
Management involves stabilizing, deciding between observation and surgery based on size, symptoms, shift, speed.
And prognosis is often guarded, with significant potential complications.
That's the essence of it. Needs quick thinking and action.
Absolutely. Well, that brings us to the end of this deep dive into subdural hematoma. We really hope that's been helpful for your revision, giving you a clear, high-yield overview.
Yeah, hopefully breaking it down like this makes it a bit easier to get your head around.
Definitely. And just as a final thought to leave you with, given what we've heard about the potential impact, the mortality, and the apparently rising incidence, what do you think are the most critical avenues for future research or preventative strategies in tackling SDH? Something to ponder.
Absolutely. And if you are prepping for exams, don't forget to check out passthemsra.com and freemsra.com for more resources.
Great stuff. Thanks so much for joining us on the deep dive today. We'll get you on the next one.